Hi everyone, lecture 5. In lecture 5, we are going to have the case of predicting quality in healthcare. And this is an example of application of logistic regression. So this lecture will be presented in 4 parts, and this is the first part. On the course map, we completed linear regression previous week, and this week we are going to start logistic regression. So we'll see the applications of logistic regressions in 2 cases here. The first case will be covered in lecture 5, which is quality of healthcare. So we're going to see how can we apply a logistic regression model to predict quality in healthcare. And this will be covered this week. And next week, we will have another case, which will be the Framingham Heart Study. So let's start lecture 5. Quality healthcare in any country, we can say one of the main goals of the government. I mean, the politicians, the physicians, and hospitals, and also by the people, the patients, is having quality healthcare. But what exactly is quality in healthcare? I mean, how can we define quality, and then how can we measure the quality, and then how can we improve the quality, right? So if we want to have improvement in quality of healthcare, first we need to be able to define and measure that. Without having a clear definition and measuring the quality, we will not be able to improve that, right? So first we need to see how can we measure, I mean, first define and then measure the quality in healthcare. So maybe one possible way is using expert and experienced physicians. An expert and experienced physician can go through each special case and then can assess the quality of healthcare received by the patients, right? So it is possible. It is possible we apply this approach, and it can be applied for random selection of patients. I mean, it's impractical. It's impractical to apply this approach for every patient in a particular hospital, for example, right? Because it needs at least 1 hour for a physician to assess the quality of a case. So it is impractical for every patient, but if we want to apply this method for, let's say, randomly selected 10% of the patients, it is practical, right? But we need to pay to that physician and or physicians, and they need to spend time to assess the quality. It is practical, but definitely it's not the best way. Okay. One possible good definition for quality healthcare could be this. A good quality healthcare improves outcomes, educates patients, and controls the costs. So as you hear, we have different aspects here. One aspect is on the government and healthcare system side, like hospitals. So over there, we need to define the outcomes, measures, and feedbacks, right? In order to measure the performance and show if we have improvement in the performance of that healthcare system. On the patient side, we need to educate patients in order to have continuously improvement on the patient's side. And at the end, we need to control the costs on government side and also on the people side. So, but in general, there is no single set of guidelines to define quality of healthcare. And so why we need to assess the quality then? We need to assess quality for proper medical interventions. If we see any error in the prescriptions for certain patients, so we can intervene and modify the prescription so we can actually improve the patient's situation, right? So here we can actually, as I said, we can use expert physicians to evaluate and assess the quality of healthcare, but we know that the physicians are limited by memory and time, and also it's too time consuming and inefficient. In case that we want to apply this method for every patient, it's impractical. But even if we consider some random selection of patients, although we will have a picture on the quality healthcare, but it wouldn't be accurate and we may not have improvement in the outcomes and so on. Okay, so this is the importance and significance of the problem of assessing the quality in healthcare. Okay. So one question arises here is that is it possible to develop an analytical tool and then replace the expert physician by that analytical tool and then apply that for a large scale? Yes, it is possible. Here we can build a model and that model can learn from expert human judgment. So how can we do this? First, we need to have a data set. It is on the previously patients that we had in that healthcare system, and then an expert physician or maybe a committee can evaluate those cases in that data set and obtain the quality of the healthcare received by those patients. Okay, so and then we will develop a model for the current data set, and results would be interpreted and the model at the end will be adjusted. Okay, so here our model is learning by the judgment of expert physician or the committee. Okay, and then after doing that, we have an adjusted model, and then we can use that adjusted model to predict the quality on new patients. Okay, so this is how can we develop a model here and then replace the expert physician by the model. We need to have a data set in order to apply a model. So in this case study, they are using claims data. Claims data actually are the data provided by the healthcare providers to insurance companies for payment. So the reason that they are going to use claims data are these ones. First, claims data are electronically available and are up to date. And then they are standardized. I mean, the insurance companies define a standard format for healthcare providers, and if they need to have claim, then the data should be provided by that standard format. Okay, it's not 100% accurate, so that's one of the disadvantage of having claim data. And also we may have underreporting situation, so it's so common in the claims data. But other data sources like the hospitals are not very accessible. So yeah, usually they are not accessible, or if they are accessible and we need to gather data from different hospitals, then each hospital may have its format, and usually they are not standard among the hospitals, so it could be so challenging to integrate data from different sources. So because of these reasons, in this case study, we are going to use claims data. So in order to have our sample data set, since we have access to a large database of the insurance claims, so in order to have a sample data set for our analysis, we randomly selected 131 diabetes patients. So here we are focusing on a particular field, and then we consider the ages from 35 to 55. So what's the reason for that? Usually an 18, for example, an 18 years old teenager will receive a different care than a 80-year-old man, right? So yeah, because of in order to have same cares, so we consider the ages from 35 to 55. Okay, and we consider the cost range between 10,000 to 20,000 again in order to have a consistent data samples. And the time period here we consider September 1st, 2003 up to August 31st, 2005. So this will be actually the characteristics of our sample data set. So now by having our sample data set, it's time to have the review of the expert panel. Okay, so our expert physicians here reviewed the claims and they wrote descriptive notes like this. So ongoing use of narcotics only on Avendia, so not a good first choice drug. Or had regular visits, mammogram, and immunizations, and also was given home testing supplies. Okay. After having the review of the expert panel, we asked them to rate the quality on a 2-point scale, just poor or good. Okay, so they provided this kind of response. For example, I would say care was poor. Okay, poorly treated diabetes, or no eye care, but overall I would say high quality. So yeah, by having this, we can actually have the quality of healthcare in a 2-point scale as poor or good. Okay. Okay, after having the expert assessment, now it's time to extract the variables. What kind of variables we need to consider here to develop our model? So first, we have our dependent variable, right? It's the quality of care that we have from the expert's assessment. So here, these are candidates for independent variables to include in the model. The first would be diabetes treatment, like the number of glycated hemoglobin tests. Okay, so yeah, this could be one independent variable. The second one could be patient demographics, but here, since we are considering just ages between 35 to 55, so we can say demographics here will have no impact. So we can ignore this variable here. And then healthcare utilization, like the number of office visits. Okay. And then providers, who are the providers, claims, how many claims, for example, we have for this patient, and prescriptions. Okay, so these are candidates for being independent variables. Okay. So after that analysis, now we have the final list of variables in our data set for applying the model. So the member ID would be the unique identifier for each observation. So this is the observation number, let's say, and then ER visits, the number of emergency room visits by the patient, office visits, the number of visits by any doctor's office, and the narcotics, so the number of prescriptions for the patient for the narcotics. Okay, provider count, the number of providers that saw or treated the patient, number of claims, the total number of medical claims for the patient, and started on combination. So up to here, I mean, we consider that the only treatment is prescribing narcotics. But here, if whether or not the patient was started on a combination of drugs. I mean, other drugs beside the narcotics. Okay, and the poor care. So this is actually our dependent variable, and if the care received by a patient is poor, this variable takes value of 1. Otherwise, it takes value of 0. So these are the variables that we are going to consider to develop our model. Okay.